So, warm welcome to everybody in this Corona. We welcome all the delegates, participants, our guest speakers to this digital CME. As you know, Dr. Professor P.C. Manoria needs no introduction. He is a legend in himself and is an institution in himself. He is a past national president of CSI, API, ICC, and is past dean of ICP and various bodies. He is awarded Lifetime Achievement Awards during the World Congress of Cardiology in 2008. He was awarded by the Bharat Ratna Award by our Honorable President APJ Abdul Kalam Sahib. Special awards in cardiology by AICIO in 2011 at New Orleans, USA. He is the Master Teacher Awards he has received in Physicians Society in 2019. He has organized several national and international conferences since last 40 years, and he is the main speaker, guest speaker in most of the conferences. Whichever conference we attend, we see Professor Manoria giving his lecture very lucidly and very enlightening the audience and captivating the audience by his beautiful lectures. So he's a master teacher, master orator, and he's the legend of our, not only the India, but across the globe. So we welcome Dr. Manoria for his deliberation.
Over to Professor Manoria, sir.
Thank you, Dr. Bharani. Good evening, everybody. For the next 20 minutes, I'll be talking on this very interesting and upcoming topic, effective cardiometabolic treatment behind metformin for Indian diabetics. The cardiometabolic strategies in diabetes are multifaceted. Metformin, as we know, is an indispensable for diabetes. Insulin resistance is one of the main pathogenetic mechanisms for diabetes, and all of us know metformin is very useful in decreasing the hepatic output of glucose from the liver. Although some guidelines like ESC suggest Sglt2 may be used as the first agent for CV risk reduction, but it would be better if we use along with metformin so that you will get better glycemic control and better CV risk reduction. Now, when we look at the cardiometabolic strategies in diabetes, we have glycemic control, we have the metabolic profile which we want to improve, because we know every 3 kilogram weight gain offsets the benefit of reduction of HbA1c by 1%. All of us know diabetes is a high risk group for cardiovascular disease, so we have to focus on the cardioprotection. And all of us know diabetes and chronic heart failure run hand in hand. If you have diabetes, you will develop chronic heart failure. If you have chronic heart failure, you will develop diabetes. What is also important to remember is that worsening heart failure and worsening kidney failure are also very closely related. They are in hand. If you have worsening of heart failure, you will have worsening of kidney failure. If you have worsening of kidney failure, you will have worsening of heart failure. So nephro protection is also a very integral part of the cardiometabolic strategies utilized in diabetes. And all of us know whenever we are trying to utilize these strategies, we always attempt that we have minimal or no hypoglycemia, because hypoglycemia is very bad for diabetics, more so for diabetics with cardiovascular disease. The glycemic control strategies are multifaceted. I'll be talking to you in the next slide. For improving the metabolic profile, we always try to decrease weight, and some of the drugs which decrease weight, all of us know, are metformin, Sglt2 inhibitors, GLP-1 receptor Agonist. And for cardiac protection, we have 2 big drugs, the Sglt2 inhibitors, which is the king for heart failure, and GLP-1 receptor agonist, which targets atherosclerotic cardiovascular disease. And Sglt2 inhibitors is also the king for nephroprotection, as we would see. So you can easily imagine that whenever we are treating diabetes, combination therapy is the way to go diabetes. Now, when we look at the glycemic control strategies, we have a panoply of pathogenetic mechanisms. Some of the important ones are insulin resistance, declining beta cell mass, incretin defect, and the renal defect. The insulin resistance, all of us know, is executed at the level of liver, skeletal muscle, and the adipocytes. And metformin targets insulin resistance at the level of liver and skeletal muscles. And the glitazone, particularly pioglitazone, which we use, targets insulin resistance at the level of adipocytes and to some extent in the skeletal muscle. The declining beta cell mass and the incretin defect, we try to target by the incretin mimetic therapies, that is DPP-4 inhibitors and gliptins and GLP-1 receptor agonists. Now, gliptins, all of us know, is the king of safety. You can prescribe it and forget. It's the most safe anti-diabetic agent. It has a glucose-dependent action, so minimal or no hypoglycemia, weight neutrality, increases beta cell mass. There's also decreased hepatic glucose production, improves insulin sensitivity, and can be used safely in CKD, and citalina can be used safely in heart failure, and citalina can also be used safely in chronic liver disease. When we look at the spectrum of GLP-1 receptor, they are more powerful incretin mimetic agents than gliptins. They also have a glucose-dependent action, so minimal or no hypoglycemia, decreases weight, decreases blood pressure, and improves beta cell mass, good safety, except for the GI side effects, and can be used even up to GFR of 15. And they are the main agents which target atherosclerotic cardiovascular disease. We also have a very important component of renal defect, and Sglt2 inhibitors are the agent by which we target the renal defect, and they increase the glucose excretion through the kidneys. They provide good glycemic control, decreases weight and blood pressure, and it is a panacea for heart failure and CKD, as we'll see. It alters the trajectory of CKD. Glycemic efficacy is decreased with decreasing GFR, but the renoprotective effects continue till 30 GFR, and data is coming up when it shows even when the GFR is less than the 30, nephroprotection is maintained. Genitourinary effects, infections are important side effects. And again, you can see combination therapy should be the rule, although the sequence of initiation may differ from patient to patient. The selection of drugs also depend on the subset of patient you are treating. If you have a patient of CKD, you can very safely use gliptins. You can also use GLP-1 receptor agonists. If you are using metformin, you can initiate up to stage 3, that is 45 to 59. If the patient is already on a metformin, you can continue even in stage B, but metformin should not be initiated in stage 4 and 5. If you're using Sglt2 inhibitors, their glycemic benefits decreases once the GFR starts falling below 45, but renoprotection usually starts when the glycemic benefits is declining and can be used even up to 30. So metformin is contraindicated in CKD stage 4 and 5. Gliptins are safe in all stages of CKD. GLP-1 receptor agonists can also be used up to eGFR 15. Sglt2 is not recommended in CKD 4 and 5. And among sulfonylurea, all of us know you can use glipizide and repaglinide in CKD. And glitazones are very safe in CKD, but are not often used because of the problem of fluid retention. When we are tackling the subset of patients of CKD with heart failure, which is again not uncommon, a very high risk group, we have drugs which can improve the outcome, Sglt2 inhibitors. You can also use metformin, drugs which have a neutral effect, GLP-1 receptor agonist, and DPP-4 inhibitors like Sita and Lina, and some anti-diabetic agents. They may have an adverse effect on heart failure, particularly Sglt and alogliptin also increase heart failure numerically, although not significant. And TZD are very well known to aggravate heart failure. Insulin treatment can also be considered also. It produces salt and water retention. If you have a patient with liver disease, you can use safely gliptins. Other agents are usually not preferred once you have a B or C class of chronic liver disease. Now, the guidelines prior to 2018 were merely glucocentric and metabolic centric, but from 2018, they have become cardiocentric and nephrocentric. And this is the ADA 2020 guidelines, which very clearly shows that if the patient is already suffering from ASCVD, CKD, or heart failure, or is a high-risk primary prevention group, you must use Sglt2 inhibitors or GLP-1 receptor agonist. And the ADA 2020 recommends first-line therapy is metformin, and then you can use. So if ASCVD predominates, if they establish ASCVD, you can utilize Sglt2 or GLP-1, and if there's heart failure or CKD, Sglt2 is the drug of choice. You can also use GLP-1 if the GFR is declining. Now, this is an overview of the cardiovascular outcome trials of DPP-4 and Sglt2. Two trials are not shown in this, the SAVOR-TB trial and the alogliptin trial, because both of them increase hospitalization for heart failure. The SAVOR-TB a statistically significant increase, and the alogliptin produce a numerical increase. TCOS, Carmelina, and Carolina very clearly shows they have ASCVD neutrality from the point of view of atherosclerotic MACE, and they can also be used in patients with heart failure. The most striking feature of the Sglt2 inhibitors is the first three initial trials are a panacea for decreasing hospitalization for heart failure. As you can see on the right side, hospitalization for heart failure is decreased by all Sglt2 inhibitors, and the onset of benefit occurs very early. If the patient in question is suffering from a cardiovascular disease, they also decrease cardiovascular death at all-cause death, as was shown by the EMPERAGE outcome and also in the subgroup analysis of the other two trials. Now, this very clearly shows that CVD and hospitalization for heart failure, the Sglt2 inhibitors are useful both for the primary prevention group as well as for the secondary prevention group. But the reduction in atherosclerotic MACE is only executed in the secondary prevention group. And DAPA-HF trial is the first trial which has shown benefit in patients of diabetes with heart failure with reduced ejection fraction. DAPA 10 milligram was compared with the standard therapy, and the subset of patients are the usual one which we see in our day-to-day practice. And within a span of 18.2, it has shown revolutionary benefits. Look at the primary endpoint. Cardiovascular death, hospitalization for heart failure on an urgent HF visit. A 26% reduction, look at the NNT, and this is on top of all standard therapy, 21. Worsening heart failure events, 30% risk reduction with DAPA. Cardiovascular death, 18% risk reduction. All subsets of patients benefited. You can see stage 2 heart failure benefited more than 3 or 4, clearly giving a message that this drug should be initiated early in the life history of heart failure. whether you have prior hospitalization or no hospitalization, the benefit is there. Patients with prior hospitalization benefit more. Ischemic or non-ischemic, both benefits. What was most striking, whether you're a diabetic or non-diabetic, the benefit is really same. This is the first trial of Sglt2 inhibitors which showed benefit in non-diabetic heart failure patients also. And this was the first very big message from DAPA-HF that it is a drug for heart failure, whether you are a diabetic or non-diabetic. The second big message was that it has shown benefit on top of ARNI, which is indeed a very historical message, because on top of all drugs it has shown benefit, a risk reduction of 25%. And therefore, diabetic patients, most of them may be on Sglt2 inhibitors, but the question arises in non-diabetic patients, which should be initiated first, DAPA or ARNI? Now, this depends on the subset of patient. If there's an issue of hyperkalemia, we would like to initiate DAPA. If there's a problem of borderline blood pressure or hypertension, we'd like to initiate with DAPA. And you can also look at the other subset or other features of the disease. And the third very big message from DAPA-HF was that prior to the, it has changed the definition, and it is poised to change the definition of refractory heart failure. Prior to DAPA-HF trial, any patient of chronic heart failure, reduced ejection fraction, if we want to submit to a device therapy, which may be a CRT or an LVAD, we'll always ask, have you taken ARNI or not? If you're not taking ARNI, go and take ARNI and come back. But now we'll be asking whether you have taken DAPA or not. If you have not taken DAPA, take DAPA and come back. So the device therapy is going to be postponed with these drugs, and this is indeed a big achievement. The cardiovascular death or hospitalization of heart failure, the secondary endpoint reduced by 25%. The total HFF and CV death 25%. And after the 4 pillars of heart failure, the ACE-ARB, the beta blocker, the MRAs and ARNI, DAPA has become the 5th pillar of heart failure. And all Sglt2 inhibitors have shown nephro protection, as is obvious from this trial, this slide. But there is a lot of change which has occurred in the trajectory of chronic kidney disease. If we go down the memory lane, we remember that the normal eGFR is 0.9 ml per minute per year. Now, when patient of diabetes develop a CKD, the GFR on an average falls to 10. And prior to the RAS era, many of these patients were submitted to CKD or were submitted to dialysis or renal transplant. The first revolution in CKD came with RAS blockers in 2005, when they improved the declining GFR from 10 to 4.4, roughly a benefit of about 50%. The second revolution came with Sglt2 inhibitor, which was kicked off in 2005, but finally documented by the Credence trial in 2019. And we know Sglt2 inhibitors further improved the slowing of GFR and CKD by 58%. So from RAS era, where it was 4.4, it has been slashed down to 1.85. And very big news is coming from the non-steroidal MRAs. You can see on the slide, the number 2, Fideron. In these 2 big trials, Fidelio and Figaro, has shown additional improvement in decline of eGFR, and the data is going to be presented in the American Society of Nephrology. So we will be having the 3rd revolutionary therapy in CKD. So although we do not have a quick fix for CKD, but these 3 revolutionary therapies, you can see, will bring down the declining GFR almost to near normal. And this is indeed a big, big achievement. Lastly, GLP-1 receptor agonist, all of us know They provide good glycemic control. They improve the cardiometabolic profile and improve the atherosclerotic cardiovascular complications. We have 6 GLP-1 receptors. You are very familiar. You are also familiar with the CV benefits. And these are the CV outcome trials. Alexa was negative. Excel narrowly missed the safety point. But the 4 positive trials were Leader, which produced reduction in the primary endpoint by 22%. Cardiovascular death was decreased by 22%, and the all-cause mortality by 15%. 13% was the reduction in the primary MACE. The SUSTAIN 6 shows a 26% reduction in the primary endpoint and a 39% reduction in stroke. In Harmony trial, a 22% reduction in the MACE and a 25% reduction in MI, and Rewind 12% reduction in the MACE. And both these drugs decrease myocardial infarction and stroke. The issue arises that these are injectable therapies and therefore the compliance is less, but now we have a semaglutide which when given orally, it has a very good data from the Pioneer 6 trial, is approved by US FDA and is going to come in our country in the next 6 to 8 months. The issue also arises Sglt2 inhibitors decrease heart failure, GLP decreases atherosclerotic events, so why not combine both these agents and get greater cardiovascular risk reduction? But the problem with this combination is an injectable therapy, but once oral semaglutide becomes available, I am sure this would be a good combination. There are a lot of prospects for this combination, which is going to be introduced in near future. And data is coming up with this combination. And last, we also tried to decrease obesity by various drugs. And what is very important is the endoscopic bariatric procedures are coming in a very big way. They are less effective but very safe, and they may replace bariatric surgery in times to come. So in summary, diabetes is a multifaceted disease. The pathogenesis is multifaceted, as you can see on the slide. The management strategies are multifaceted, as you can see. The subsets are multifaceted, and therefore combination therapy is the rule when we are managing diabetes patient, and therefore all of us must be very familiar with all the available anti-diabetic medications and initiate in a proper way. The sequence may vary, but ultimately all of them would require combination therapy. Thank you very much for your kind attention.
Thank you, Manoria sir. It was a very nice presentation from your side. There is a question from me. What is the relative difference between the new available heart failure drug Vimata and dapagliflozin in the management of heart failure, and how do you look at the combination of these 2 drugs? Obviously, the cost
this is a very interesting question. Now, in heart failure, you must remember that heart failure is a disease which runs a malignant progression. If you're talking of a non-diabetic heart failure, 5-year mortality is 50%. If you're talking of a diabetic heart failure, the 5-year mortality is 85%. Only 15% of diabetic heart failures survive at the end of 5 years. And therefore, when we are treating these patients, our attempt is to use all these 5 drugs. The sequence of initiation may be different. Suppose a patient is on beta blockers, he's on an AC inhibitor, on MRAs, if he's not responding, or otherwise also, we would like to switch him to ARNI or add DAPA. As already told you, if his blood pressure is 80/50 or 90/60, and there's problem in initiation of ARNI, we would prefer DAPA first. If there's a problem of hyperkalemia, we would prefer DAPA first, but we'll try to use all these drugs. ARNI is unique in the sense that all first 4 pillars of heart failure, they modulate through the RAS pathway. ARNI is the first, DAPA is the first drug which has shown benefit independent of the RAS pathway. It doesn't benefit through the neurohormonal pathway. And if you remember the subgroup analysis of the DAPA-HF, the maximum benefit was seen in the subset of patients where NT-proBNP levels were less. So when you look at the quartiles, the benefit was maximum in the lowest quartile of NT-proBNP. And when we talk of heart failure with preserved ejection fraction, although the trial, DELIVER trial and other trials are not yet out, but there is a high probability that may benefit heart failure with preserved ejection fraction, because some of the patients in the DAPA-HF had preserved ejection fraction and they improved it. Another thing we must remember in heart failure, which is a malignant disease, one of the biggest enemies or the biggest barrier for improving prognosis is the patient and sometimes the physician, because there's a misconception that heart failure is a stable disease. Heart failure is never a stable disease. It can kill you next moment by sudden cardiac. It can make you hospitalized for acute heart failure. So a patient often tells us that I'm doing okay, I have some hypertension, don't add on drug. Combination therapy should be the rule and should be enforced if you want to improve the outcome of patients. And the basic difference between DAPA and ARNI, DAPA is independent of neurohormonal modulation. The other drug, all other drugs act through the neurohormonal modulation.
Sir, there is one question from Dr. Parashar Bhopal that please give some enlightening on the semaglutide.
Semaglutide is an oral GLP-1. All GLP-1s are destroyed in the stomach and therefore they are ineffective. This, by a special technology, it has become orally effective, and this drug has shown a 50% reduction in the all-cause mortality and cardiovascular mortality, although the primary endpoint of cardiovascular death, MI, showed a numerical decrease which was not statistically significant. And based on the data of all-cause mortality and CV mortality, it has been approved by US FDA, and it is believed that a combination therapy of oral GLP, oral semaglutide and SGLT2 would be a wonderful therapy for a holistic reduction in cardiovascular risk, because the SGLT2 targets heart failure and CKD, the GLP-1 targets predominantly the atherosclerotic complications, and Novo Nordisk is coming up with oral GLP within the next 6 to 8 months. So there's a lot of excitement because injectable GLPs, all of you know much better, the diabetologist, is difficult for the patient to adopt an injectable therapy in the long run.